Good evening. Well, thank you for joining us for today's webinar, Living with Prostate Cancer, organized by the Florida Society of Clinical Oncology. FLASCO is a member-supported state society that focuses on supporting and representing the oncology workforce of Florida. Together, FLASCO is the voice of oncology in Florida. All of the individuals presenting this evening are members of FLASCO, and we appreciate their support. My name's Carrington Mason. I'm a board-certified urologist specializing in prostate cancer care at Cleveland Clinic in Vero Beach, Florida. And our topic today is living with and living alongside prostate cancer. I'm honored to serve as a moderator and keynote speaker for this evening's webinar. Before we begin the presentations, we'd like to thank AstraZeneca for sponsoring this webinar and making it possible for us to share this information with you this evening. I'd also like to let everyone know that this webinar is being recorded so that those who are unable to attend can view it at a later time. Please note that your lines will be muted for the duration of the webinar. Toward the end of the meeting, we'll host a Q&A session, and we encourage you to submit questions or comments via the Q&A chat feature at the bottom of your screen. We'll discuss as many of the questions that are submitted as time permits. I'd like to introduce our first keynote speaker, Dr. Ali Kassarian, a board-certified urologist from Kassarian Urology in Jacksonville, also an expert in prostate cancer, and he'll provide us an in-depth overview on prostate cancer as well as locally and advanced metastatic disease. Welcome, Dr. Kassarian.
Thank you guys for having me. I hope you can hear me okay.
I hear you well, loud and clear.
Perfect. I appreciate the honor of joining you for this webinar, and especially in Prostate Cancer Awareness Month, and talking about obviously for me what I think is a very important topic is prostate cancer. Obviously for me as a urologist, everything kind of starts with screening, and then obviously it moves into the localized prostate cancer. But I think one of the most rapidly moving and exciting fields or areas with prostate cancer these days is advanced prostate cancer, as is almost like it seems like on a daily basis we're getting new advances in technology, medications, guidelines coming in that allow us and our patients a better way of dealing with a disease process that not too long ago, and I'm not that old, my wife reminds me that that's not the case on almost like a weekly basis whenever I talk about these things. But we all remember the days where prostate cancer used to present with metastatic disease. I'm very fortunate to work with my dad, who reminds me that prostate cancer used to present in about a quarter of the men with metastatic prostate cancer. And not only is that not the case these days, but we're moving in a realm where men who present with disease like that, we're beginning to think about that could potentially move into the curative phase of some of the newer next generation hormonal blockade. The pathways are having such successful return and results that we're beginning to re-engage our thought process in how to manage those diseases. I mean, Dr. Mason, wouldn't you agree that in your line of work, the disease that you're seeing that before had very few options and very few discussions that were hopeful are now really hopeful?
Absolutely. We've got something available at every turn of the road to provide at least a couple of options. So it's not like the old days.
The way I talk about prostate cancer to patients, which is a silly analogy, but it seems to work, and I think it engages patients at every step of the way, is that there are 4 types of prostate cancer. There are rockets, rabbits, and turtles, and snails. And I really think the whole reason for us to screen, regardless of the viewpoints of people in terms of the controversies of screening for prostate cancer, which really remains one of the most controversial cancers in the world of malignancy. And again, from my standpoint as a urologist, that may not seem like a really broad statement, but for you, Dr. Mason, that may actually ring a bit more truthful, since you deal with a lot more malignancies than we do as urologists. But the whole reason we screen is to find prostate cancers at a point that we can engage in a curative intent to avoid people showing up with metastatic disease later on in their lifetime. And then you have the rabbits. Rabbits are prostate cancers where the prostate cancer is still confined to the prostate, but they're cancers that are intermediate risk, higher risk cancers, where the idea of curative intent at the time of diagnosis or very shortly thereafter can bring therapy at a time where curing the cancer avoids later metastatic disease, which could potentially be fatal in that patient's lifetime. And then, further controversies lie in those turtles and snails, slow growing, slow moving prostate cancers, where often, the benefits of cure may be far outweighed by the risks brought by those cures. So you don't necessarily want the cure to be worse than the disease, especially when the disease in those turtles and snails often is not fatal, and probably for many of those gentlemen is never going to be fatal. So that's where, one of the beauties of managing prostate cancer and one of the challenges is figuring out who is going to be in which of those pathways. Unfortunately, very few of our patients are in that rocket phase, although with a lot of the screening controversies over the past decade, we're finding more and more patients may be showing up with more aggressive disease. What are your thoughts along those lines?
Well, we have so many more diagnostic capabilities now than whenever I finished my training in 1997. As a urologist, we see prostate cancer. We treat prostate cancer with an operation, or if it's fairly advanced, we'll address it hormonally. And that was really the game, set, and match. So nowadays we're able to tailor therapies and we also understand the disease better in terms of what the biology is. Not every prostate cancer is the same much as what and I like your categorization between the rockets and the snails and the turtles, because that's a great assessment.
Yeah, so when we as urologists see men with prostate cancer, and it really starts with the screening. And I think that's really interesting. A lot of times when people come to us in terms of what are your thoughts in terms of screening, and the PSA test and how to screen, I think we have to be really respectful of the fact that conversation needs to really engage our primary care physicians, which are really the gateway to that conversation, and the gentlemen who have to engage in that screening in this day and age where, we're really asking a lot of our primary care doctors who really have a lot to take on in that 10 to 15-minute visit for patients who have to do a lot, to have a patient-centered discussion about all the risks and benefits associated with prostate cancer screening. That's a really labored and a long conversation to ask them to do, but again, an important conversation. I think, and the guidelines are constantly changing, how to go about screening, the benefits of screening. And so I think that's a very important thing to think about. So I encourage everyone listening to know your own risks, know your family history, men of African ancestry, African-American men, people with BRCA gene positivity or other familial risk factors, and know your family history, especially people with first degree relatives who have prostate cancer, those gentlemen, or even people with breast cancer family history, be mindful of those genetic associations. And we're learning more and more about other genetic potentials associated with that. Start screening earlier. Think about screening in the 40s, 45. And there are a lot of studies that actually show the benefit of that. One study that I carry close to my hip in Malmo, Sweden. They did a really, really very, very interesting study, which is a bit, further than a few days ago. This has been going on for a while. And the study from this was from a bit ago, and they followed people for their lifetime. And some colleagues went back and found the blood, really took them out of the freezers, found the PSA, and found that first PSA in the mid 40s was the most predictive of what someone's lifetime risk of prostate cancer was going to be. So they found that if someone's PSA with an average risk for prostate cancer was less than 1, their lifetime risk of having a prostate cancer that was going to potentially impact their lifespan was really low. they did follow-up studies and found that if someone maintained a low PSA less than 1 at 60, their lifetime risk was really significantly low. So Memorial Sloan Kettering actually has a pathway really based on that first PSA in the 40s and what those follow-up PSAs are following up and leading up to the 60s. So one can have a really, really intelligent and data-based screening pathway based on those first PSAs. And that's really important in terms of someone who has a family history, African ancestry, and especially if you have a high risk category and a family history associated with prostate cancer. You can also do things in terms of using smarter screening tools and advanced diagnostic tools that we have these days. The multiparametric MRI has been shown to be really, really impactful. Biomarkers, things like the 4K score, the exosome DX test, or multiple other tests like this coming in. And one thing as a patient to keep in mind is that these tests are designed not to create an assembly line of biopsies to do. They're designed to avoid unnecessary biopsies. And in doing so, we avoid the biopsies that we can safely avoid, but also we don't miss the biopsies that we should not avoid, meaning that we don't avoid the rockets, but we look at possibly avoiding the biopsies that may really have no cancer, but also possibly those very, very low volume, low risk turtles and possible snails, which are likely not to kill men, or if they're going to show up, we show up later by following them very closely from that standpoint. So you can come up with a very smart screening pathway and not avoid cancers that you don't want to miss, and you engage the gentleman in their own screening pathway with conversations that engage them in that process. And I think that starts the conversation of how to manage your prostate cancer risk by starting the conversation with screening. So I think that's where the conversation starts, so that hopefully you avoid needing to talk to Dr. Mason in the future. I mean, I think that's where everything starts, is screening. I ask you as a medical oncologist, how often does a conversation with screening start in your world?
Oh, I'm a urologist.
Oh, very good.
And prostate cancer survivor for 19 years. So
well, let me ask you this then. So for your aspect of things, as a prostate cancer survivor for 19 years, what do you think the world is, as you have seen it shape, from your perspective of things, which is even more interesting, from that standpoint?
I truly think that the discussion is really a bigger part. As I alluded to earlier, it used to be we didn't have a lot of things to offer, and it's like you're getting an operation, you're going to radiation, or you're going to get hormonal therapy, or you're going to do nothing. And that was sort of how we began and finished the conversation. And I think now there are much more thoughtful conversations that go along with this. We also have more data, as you're alluding to, as far as biomarkers and just MRI imaging that we get that allows us to do focused biopsies, and we can sort of understand what sort of volume of disease we're going to. And then there are certainly a number of treatment options at every sort of gradation of disease. I really think it focuses for me around the patient's understanding risks and benefits. They need to know what the life is going to be like afterwards. There's no great choice in terms of prostate cancer. There's great choices in terms of disease control, but as far as controlling, as far as just, they need to be able to thoughtfully understand what the side effects of treatments are going to be.
So, I mean, when you have discussions with patients regarding, the every step of everything, and even starting with screening, does your history have an impactful, eye-opening revelation for the patient? Because a lot of times, you as a urologist who's, never had a biopsy, for example, or never been through something, a lot of times when patients hear something by someone who's been through things, it has a lot more weight. You can see that a lot of times with men who go through radiation therapy, the waiting room of the radiation center, where you have men going through the same thing together. Essentially you've got a built-in support network from that standpoint. So it holds a lot of value from that standpoint. So you, as a urologist who also has been through that aspect of things, it probably holds a lot of weight in terms of what they're going through every step of that decision pathway.
I can certainly empathize with every moment of all the care.
And that's very powerful, from that standpoint, because it's not an easy decision. And that's one of the, I think, the beauties of managing prostate cancer. And what I know personally, I really love about taking care of prostate cancer, because what in medicals they talk about every patient's different and things of that nature. I think with prostate cancer, that truly is the case, because regardless of the pathology, regardless of what someone's going through, everyone's perspective of what's important to them is different. And what's nice about where we're headed with the world of prostate cancer through every spectrum of the disease, we're moving in a place where our pathways allow for a personalization of care that allows us to be able to offer not only curative intent with very good results, but also a focus on the quality of life, and a very specific quality of life conversation that can be very, very specific to what's important to the gentleman that we're talking to. And I think, one thing, I was just at a meeting up in DC of the Focal Therapy Society, where we were discussing a lot of focal therapy options for the management of very specific types of prostate cancer, where the MRI scan shows a targetable lesion. You can kind of take a look and see for patients with very specific intermediate risk types of prostate cancer that you can target. There are a lot of different technologies that one can take a look at, like high intensity focused ultrasound or cryotherapy options. There's Tulsa Pro, which is an MRI based technology. There are all these different technologies that one can address. The albatross around the neck of most of these technologies is whether they're paid for. And that's something that I think we can have another webinar to discuss that. But if one can appropriately look at that aspect, it again brings that conversation that prostate cancer is moving into a balance of cure with a very important respect for the quality of life measures that are important for the gentleman we're speaking with. And I think where that is important, it takes away that fear of screening, a fear of discussing what to do next. And I think hopefully it'll bring everyone back to the table of appropriate screening, appropriate diagnosis, and then a very specific personalized treatment of prostate cancer, regardless of the stage of degree of the disease at the time of diagnosis.
Well, I think those are all valid points. And, so as we evolve through this understanding of prostate cancer, and as I alluded to, I finished my training program in 1997, and we were all about you treat the entire prostate gland. And then there were considerable upstarts that came along with the concept of, well, let's just treat portions of the prostate gland. And, as we have the understanding, as you mentioned, the multiparametric MRI, we get a better understanding for what disease is involved in the prostate gland, and it allows us as clinicians to certainly interact and guide our patients to go down different treatment pathways. And it's interesting. They give us an hour to talk about treatments and whatnot and all the aspects. I mean, for me, it was a 7-year training program, so it's interesting to distill it down to such a short time period. As urologists, when we're initiating that sort of diagnostic pathway, the patient trying to figure out, do they have cancer, and if they do, is it localized, is it advanced, that sort of thing. Why don't you just outline a little bit the concept between local versus advanced and metastatic disease for our listeners?
So again, you can kind of go back into, the very simple aspect of that rockets and rabbits and turtles and snails. So obviously, when we look at, metastatic versus localized prostate cancer, one is the prostate cancer confined to the prostate versus is it outside of the prostate, and then how far outside of the prostate. So when you're looking about localized prostate cancer to within the prostate, that is one thing that we look at from that standpoint. So when we diagnose a prostate cancer, the first thing we look at within the prostate is, one, are we within the capsule, and looking at the grade and stage of the prostate cancer and the risk categorization of that. So we look at the PSA level, we look at the rectal exam finding, and the Gleason score, which is the grade of the prostate cancer. And what that is, the pathologist looks at the cells under the microscope, and they give us two numbers. The first number, which is the most common area that they see under the microscope, and the second one is the second most common number, and they give a total score. And this is a little bit confusing because they say each of those individual numbers score from 1 to 5, 5 being the highest number, 1 being the lowest number. They add them together to give a total score that ranges from 2 to 10. Where it becomes a little bit confusing is the lowest score is a 3 plus 3 equals 6. So you're kind of starting the lowest score from a 6. So some people are a little bit confused. What I do to kind of simplify that is thinking about 7 as a fence that divides more aggressive cancers, like 8, 9s, and 10s from the less aggressive cancers, which are like 6, 5s, and 4s. And these days, we really don't see 5s and 4s anymore. The pathologists kind of got rid of that in 2007. And they've recently come up with actually another scoring system, which is a 1 to 5 scoring system called the grade group classification, which tries to simplify that. Within that 7 family, that they try to make that a little bit better stratified as well. So if the 3 numbers first, so if you have a 3 plus 4 equals 7, again, looking at that fence analogy, if the 3 numbers first is kind of the side of the fence leaning towards the less aggressive cancers, so it's a less aggressive cancer. And if the 4 numbers first is on the side of the fence leaning a bit towards the more aggressive cancer, it's a bit more aggressive. So a 4 plus 3 is a bit more aggressive than a 3 plus 4. And then again, I kind of talk to patients about that 1 to 5 scoring system. The 1 is the 3 plus 3 equals 6. You go up in aggressivity. The 2 is the 3 plus 4 equals 7. The 3 is the 4 plus 3. Anything equaling an 8 is a 4, and the 9s and 10s are a 5. So you take that information and you stratify risk from low risk cancers, which have a low PSA less than 10. You don't have a nodule or a very small nodule, and a Gleason score of 6. So those are the cancers that you can start thinking about active surveillance, or you can monitor the prostate cancer with essentially PSAs every 3 to 6 months. And you can think about a repeat biopsy at about 6 to 12 months. A lot of us use an MRI-based protocol if we can. And based on that, you can talk about how often you can follow up with surveillance biopsies. The guidelines talk about doing it every 1 to 3 years, depending on the amount of disease that you have and the discussions, personalized discussion with the gentleman that you're speaking to and their family. Intermediate risk cancers are those 7 prostate cancers, PSAs between 10 and 20. And if you have a bit more prominent nodularity involving half or both sides of the prostate. And then you have the more aggressive prostate cancers, which actually have a nodule that feels like it's pushing out of the prostate, a Gleason score or that grade of an 8, 9, or 10, and actually a PSA above 20. And those are aggressive prostate cancers that have a higher potential of either at that time on imaging having prostate cancer out of the prostate, or in the future getting out of the prostate. And so those are the cancers that are rabbits, but have a rabbit that may be a little bit quicker, faster, maybe having a little bit more potential of becoming a rocket in the future. So that's where you're worried about more locally advanced prostate cancer risks in the future, meaning that if you remove the prostate, or if you did radiation therapy, could you at that time or in the future have cancer pushing out of the prostate at the capsule, maybe at the prostatectomy? Could you have a higher risk of a positive margin at the prostatectomy? Could you have lymph nodes that are positive? Metastatic disease means that either at that time of diagnosis or later in the future, you have lymph nodes that are a bit higher up in the abdomen. Could you have bone metastasis, meaning that you do some imaging, either a bone scan or some of the more modern advanced imaging studies. Right now, one of the imaging that's very hot right now is a PSMA PET scan, which we'll talk about. There's an Oxyman scan. These are, or regular CAT scans show things which show that you have disease that is not confined to the prostate, and sometimes you're worried about disease not being confined to the pelvis, and that is when philosophically the cat is outside the bag. So you have to think about how to contain the disease from being further expansive or further spread, and that's whenever we think about beyond just local containment with some of the localized therapies, like we were discussing before, the prostatectomy, radiation therapy. Now we're having a lot of very elegant discussions about focal therapy options, but then you think about ways of managing the disease for more systemic therapies, such as hormone blockade. For years, that's all we had. You give a shot to bring down the testosterone level. Now we have a pill that is very well tolerated to do that. But Now we have actually next generation hormone blockade medications that very specifically block the testosterone receptors at the prostate cancer cells, with very, very wonderful results in terms of containing the prostate cancer in the short term and the long term. And also in terms of if people have radiographic evidence of disease, meaning that you have a PET scan, bone scan, CAT scan evidence of disease, that a very significant percentage of patients who have evidence of cancer on those images in the near and far future are able to fight the disease with regression of those findings. And so this has really kind of changed the way that we manage these diseases, because it allows us to be able to kind of target this disease and potentially return in terms of a philosophical aspect of, can we use these medications and then kind of rethink going after treating the disease with radiation and potential surgery in terms of a kind of a rethinking of curative intent for more advanced disease. So I hope that answered the question in a bit of a way of putting together how we think about the pathology and the oncology of prostate cancer.
Well, that was a great outline. I appreciate it. In your practice, when you're sitting with patients and whatnot, are you using any of the minimally invasive therapy? I mean, I shouldn't say minimally invasive, the focal therapies for prostate cancer at this point?
Yeah, so for me, the way I first got introduced to focal therapy, I did a laparoscopic and robotic surgery fellowship in Paris in 2007 to 2008, and one of my earlier days in that fellowship with one of my mentors there, one of my attendings who's now a dear friend, Eric Beret. We're walking past this room, and there was this really strange machine with it was a table with a probe sticking out of it and kind of like a computer next to it. And I'm like, what on earth is that? And he's like, oh, that's HIFU, in a very, very typical French accent, which was made everything sound much smarter. And I was like, what is HIFU? And he's like, high intensity focused ultrasound, which is basically an ultrasound technology, kind of like taking a magnifying glass and trying to burn a leaf. It would bring a technology to a focus. And basically what this would do is allow for the delivery of that ultrasound energy to a very focused target towards the prostate. And they use this to treat both the whole prostate, and often this was the beginning of, if they found something on an MRI scan, and at that time they did what's called a saturation transperineal biopsy, and they found just an area. They were beginning the initial research in collaboration with the University College of London on the concepts of focal therapy. And I just thought this was the greatest thing ever. And so when I came to the United States, I was very fortunate to get involved in that. So HIFU was one of the first things that I tried. Cryotherapy is another one. We're beginning to look at some focal laser ablation technologies that hopefully we'll be able to do in the office setting with things like nitrous oxide and a prostate block. So, and Tulsa Pro is another one that we do. So we look at it, and the way we approach this is really, it starts with appropriate selection. So I think where focal therapy succeeds is looking at the right treatment for the right gentleman at the right time. So that really you're looking at Gleason 3 + 4 = 7 disease, which is appropriately sized in terms of the MRI lesion. It is amenable to focal therapy. And then when you talk to the gentleman in terms of their goals for therapy, they have an understanding of what that means. You're basically treating the area, and either as what's called an hemiablation, or you're treating the area with a margin. And they understand that there is a possibility that you can either have disease on the other side of the prostate. So it's kind of like active surveillance plus. And what I tell people, and most of the data supports this kind of outcome, about 8 out of 10 people who undergo focal therapy are going to have a good result where they're not going to need something else. And especially they're not going to need a progression to radical prostatectomy or radiation therapy in the future. They may need another focal therapy of that area, or potentially another cancer showing up in some other place in their prostate. And if they're okay with that, then they can potentially enjoy the benefits of a preservation of function with this concept that the more prostate you preserve, the more function you preserve. So it's essentially an understanding of that. And the way I philosophically think of it is very similar to a shift in philosophy of treatment from the Halstedian radical mastectomy to the segmental mastectomy or the lumpectomy for breast cancer. But it requires appropriate selection and appropriate conversation with a gentleman so you understand what you're doing. If you have a high-risk prostate cancer that's affecting the whole prostate and you do focal therapy, it's not going to be successful. So I think it requires a very, very appropriate discussion, and every treatment has their own benefits and side effects and appropriate types of cancer and locations to how you treat and how you use it appropriately.
And I think one of the to track on your comments, one of the most challenging things is many times patients come in and see us a bit like McDonald's. They'd like to go through the drive-through, get their fries, and they're out. When we're talking about the less invasive therapies or the focal therapy, I try to emphasize to patients that this is an ongoing relationship. This isn't a finite occurrence. And even for patients who decide on definitive therapy, as I mentioned, in my own circumstance, 19 years along since I had my prostate removed, I still get my annual PSA studies. And so managing prostate cancer is not just a one-stop shop thing. I never use the word cure. Cure gives you think like, oh, we're done. We don't have to worry about it anymore. So I always, I no evidence of recurrent disease is what I prefer to utilize, just to sort of establish in everyone's mind that we've got this ongoing issue that we need to keep up with. And so again, as we've sort of said, we start out with a stratification of where you are with the prostate cancer. And, we have our National Cancer Care Network that sort of has this great simplification that will guide us into a low risk, and then the favorable or unfavorable intermediate risk, and then high risk patients. I think I'm challenged to talk about sort of the conventional therapies that we've been utilizing and still utilize to a great extent. The big pieces really come in the form of radiation and surgery. It started out that we would do an open operation where we'd make a small incision from the belly button down to just above the penis and go in and remove lymph nodes and remove the prostate gland and bring things back together, with the evolution of initially laparoscopy, which I was one of the laparoscopic patients that predated the common utilization of the robot.
That's where my training started. I did my first prostates outside of training laparoscopically. People looked at me like I was nuts.
Trangiano?
Yeah, I did it with Guy Valencian and his team.
Yeah, okay. Well, so the robotic prostatectomy, I think, saved the backs and necks of many urologic surgeons, because the laparoscopic operation was very taxing on the surgeon as well as the patient. And the advantage of doing these minimally invasive approaches, there's a quicker return to the patient's activity, whether it be work or just their activities of daily living. There's a diminished blood requirement for blood transfusion, which is negligible in our practice, and I'm sure yours as well. Whereas the open operation used to be an exquisitely bloody operation, and even in the best of hands, up to 25-30% of the patients would require blood transfusions. All that's gone away with the advent of the robotic and laparoscopic procedure. We also have other modalities of treating this, though, and I think we've covered the focal therapies, but radiation can be done in a multitude of formats. It can be done with conventional external beam radiation therapy, where the patient goes into the radiation center once a day, Monday through Friday. I always joke with our radiation oncologist, how cancer knows you can take off Saturday and Sunday, I don't know, but we're stuck going to the hospital every day with surgeons. But there are also brachytherapy, which is essentially treating with internal radiation of the prostate gland. And there's two formats by which you can do that, either with seed therapy, which many people have heard referred to, or something that I practiced in Dallas, Texas for 21 years before coming here 5 years ago. And I had a very large high dose rate brachytherapy practice where we, with a patient with a spinal anesthetic, will place some needle apparatus around the prostate gland that allows us to paint radiation around the external surface of the prostate, and it's very successful. And for the lay public who's listening to our conversation, it probably sounds like a bunch of gobbledygook, but this is all about the conversation that you have with your urologist to sort out what sort of disease you have, what sort of available therapies are there at hand, what other therapies are available in your local communities and also elsewhere here in the region. And we're very fortunate. I was in Colorado yesterday, and there are limited areas where you can have certain aspects of care, whereas here in Florida, throughout our state, we've got a very high level of urologic care. So there's a great deal to be said for that. Focal therapies, for me, I came from the training ground where that was just, it was heresy. And then I worked with Mark Emberton in London, and we were using electroporation, where and actually with the nanoknife technology that's available here, it's something that we initially discussed 10, 12, 14 years ago, and we thought this is never going to go anywhere. There is so much that's an evolution in the field of urology, not only in the interventive treatments that we have available, but also in terms of medical therapy and also the diagnostics. You alluded to the PSMA scan. This is a PET CT scan that we had sort of a light version of available 5, 6 years ago, 7 years ago. And now we've got this much more intense version of this PET CT scan that allows us to visualize things that we didn't see before in terms of recurrences with prostate cancer and stuff that may be occurring locally, and would have us be able to offer, maybe after surgery, some localized radiation rather than having to plague someone with a hormonal intervention that may offer them a different side effect panel. So we could go on for forever and ever and talk about what the possibilities are for the future. And I don't think we need to drag that on.
I mean, one thing that's amazing about the PSMA PET scan, you know, for some of the very advanced patients, you know, PSMA scan, which is a prostate specific membrane antigen, is, you know, there's also even therapeutic implications. So you can potentially have the same, you know, what is called a ligand, that the radio tracer, the X-ray dye that picks up the thing you see on the imaging, they actually have a therapy that can then be targeted to that area. So it's very impressive for the future implications of what this means. You know, they can use it now, but not every patient necessarily may be a candidate for that or need that. But the implications of what the future is going to hold for where our research may take us is very, very impressive. You know, you mentioned electrovaporization, the IRE. You know, this is electrical energy which goes in there and kills the cancerous prostate tissue, but preserves all the other tissue in between it. I mean, that's very, very clever. People are doing research on nanoparticles where you basically kind of give a signal of these nanoparticles, almost like little robots that go in there, and then you give a little signal of light that then wakes them up to treat the organ that's around there from that standpoint. I mean, very, very interesting things that are coming in the future that allow us to be more precise, more accurate as we're trying to do with our diagnostics and therapies. And I think, you know, the future of prostate cancer is very, very bright, from diagnosis to more focal therapies, to how our surgeries and our radiation is aiming to be more targeted. And even with advanced and metastatic disease, we're trying to be more targeted, kind of learning from a lot of what our colleagues in breast cancer have done over the years. There's a question down here in terms of genetic aspect of things. We're learning more and more in terms of genetics, implications of race, the genetic, the social, the socioeconomic aspect of things and the implications thereof. So we're constantly learning how all of these things work hand in hand in terms of understanding risk, on understanding implications of that risk, and how to bring the work from the bench to the bedside and very quickly try to apply that to the patients on how to better screen, how to better treat, how to better diagnose, and how to better cure. And I think that's very, very impactful in terms of how we treat a disease that we found what happens when we don't screen appropriately. And we really saw a very, very quick shift in the stage migration where we began seeing men show up with higher risk disease. And it was really interesting during the pandemic, where the operating room shut down, we went to telemedicine and things like that. It wasn't really impacting the patients who were already diagnosed, and we couldn't get them to the operating room fast enough. It impacted the men that couldn't get to screenings fast enough. And that's really, really impactful in terms of the power of when the conversation should start.
Just to there's one thing that I think we may have left out, or I want to touch on before we move along. Getting back to PSAs, and in our community here locally, there's a lot of still bad press, and a lot of people don't understand the whole PSA was good, why do they do it? Oh, now PSA is bad. And PSA is one of the best diagnostic markers that we have available in all of medicine. And as far as also a marker to be followed in follow-up of care, it
gets a little bad press unnecessarily, in my opinion.
Absolutely. Well, the thing is, there's a political entity that was assigned several years ago to look at colonoscopies, mammography, and other screenings such as PSA. And there were groups of people who were not necessarily experts or even practitioners in the field of study that got together and were part of this institutional screening recommendation that was made forward. And PSA was made into being a bad thing. Well, first of all, PSA is always to be coupled with a digital rectal examination. And many of the practitioners that I see in family practice and primary care neglect to examine the patient's prostate. Probably 15 to 20% of the prostate cancers I pick up have a normal PSA, and without the digital rectal examination, we wouldn't have any suspicion at all. And unfortunately, these tend to be the more highly aggressive prostate cancers that are not putting off as much of the PSA. So before we trail off into our conversation about the patients' questions and answers that are available, I just wanted to say that PSA is a great test. It's a great great marker for following treatment. And the interesting thing is, whenever they came out and said, "Oh, PSA is bad," it was on the front page of the New York Times. Whenever they issued the retraction, it was section C, page 28, and a little square in the back that said, "Well, gosh, maybe we were incorrect in reporting that." So it saved my bacon. So I'm still a big fan.
No, I'll tell you, I don't disagree. I mean, I remember it came out of my fellowship in 2008. That first year is whenever, the initial beginnings of that process came into play. And then 2012 was whenever that final recommendation came out, and all the different organizations each had a different opinion. The AUA first said one thing, and then they said another. So we make it very, very confusing. But one cannot deny that when PSA first came out, and through the decades of it being out, prostate cancer mortality significantly decreased. And whenever these recommendations went against screening, we found prostate cancer mortality went up when people stopped screening. So that is not, and a stage migration was noted, where we're beginning to see more aggressive disease, metastatic disease increase from that standpoint. So screening does save lives. So I think the key factor is figuring out which prostate cancers need treatment when, and finding the appropriate prostate cancers that could possibly be safely monitored with things like active surveillance, the appropriate treatment for the right gentleman at the right time with the appropriate discussion. But I think kind of throwing out the screening as a means of avoiding a treatment that may not suit the cancer is not the answer. I think screening appropriately and starting screening at the appropriate time, I think, and most urologists that deal with a lot of prostate cancer would agree that that's the better and the smarter way to go from that standpoint. And again, I personally, I know the prostate cancer, the rectal exam seems to be, in my opinion, unnecessarily controversial, but I perform a rectal exam on anyone I see, and I as well find prostate cancers. This week, I found a gentleman who the only way we found a Gleason 4+3=7 prostate cancer with a PSA of 1 was a rectal exam that found a pretty impressive nodule that there was no other way we would have found this. He had a stable PSA of 1, and the only way we found this was a rectal exam. And, for as much of the data shows a variety of different things, and there's controversial even amongst urologists, I have no other answer that the fact that I too, like you, when we look at our own data, through about 1,400 MRI-based biopsies we've done, we still find prostate cancers that the rectal exam was the only way that these gentlemen got to the biopsy. So I agree with you.
Well, we kind of covered the waterfront rather quickly, and Dr. Kassarian, thank you so much for your great presentation. We do have time for questions and answers, and I know several of you have submitted on the Q&A chat box. If there's others who would like to submit questions, that we'll certainly be glad to address. So let's move on to the question and answer portion of the agenda. And if you haven't submitted your questions, please do so in the chat box. And I'll read as many as time permits. But so our first question is: do you see many examples of damage to the bladder from prostate cancer radiation after the prostate is it says after the prostate is removed? For example, bleeding and other symptoms. Just to be clear, with radiation, you're not actually removing the prostate, you're treating the prostate gland, and so there is prostate tissues left behind. But do you want to comment about the
So you can actually see injury, if you will, or side effects that are bladder centered from radiation therapy. We actually up here in Jacksonville, Florida, the radiation team that we work with, we're very fortunate that because of their, just like most things, just like with surgery, when you're looking at radiation teams, especially with prostate cancer, you want to find teams that have a good knowledge base in terms of how to manage prostate cancer and are high volume. And so we've been very fortunate where our radiation colleagues seem to have not only do a great job in terms of the curative results that they have, but also a very low side effect profile. However, if you look at where the prostate sits, it sits below the bladder, the urethra runs through the middle of the prostate, you have the sphincter mechanism below it, the rectum's right behind it. So the possibility of the bladder neck and the bladder having issues related to a rectal aspect of things, both of which could potentially cause urinary symptoms, frequency, urgency, potentially having blood in the urine, a rectal aspect of things in terms of rectal frequency, blood in the urine, things like radiation cystitis with bleeding, meaning inflammatory changes to the bladder, same type of thing with the rectum. All of those things can happen. With the specific question of if you've had a prostatectomy, then you've had either a positive margin or extra prostatic extension, meaning that when the prostate was removed, there was an extension of the prostate cancer beyond the capsule. There are some studies that have shown that especially if the PSA starts uptrending, doing what's called adjuvant radiation therapy or salvage radiation therapy to the base of where the prostate used to be, or the prostatectomy bed, could potentially lower the risk of recurrences. Then you could potentially similarly have irritative changes, like I described, to the bladder tissue as well. And so that could cause bleeding. It can also cause irritative symptoms that cause urinary symptoms. And it also can potentially create some scar tissue, which can cause an amplification of incontinence and also strictures, where you could have obstructive symptoms and urinary retention. So a lot of times, if you have that scenario where you've had a prostatectomy, a lot of times we let your continence set. So we wait 6 months, 12 months often, and see where your urinary control is set, and hopefully you're able to urinate without significant urinary incontinence before we make that consideration. And nowadays, in that scenario, we can do things like oncotype testing. We look at genomic testing, which there are three. There's a Polaris test, there's a Decipher test, and an oncotype test, where it can give us some information. And really, actually, Decipher and Polaris are the only one that you can use after the prostatectomy that can give us some genetic testing to give us the risk of recurrences after a prostatectomy in certain scenarios that can decide whether or not you need radiation therapy, or at least facilitate the conversation so that you can really make an informed decision.
Well, appreciate that detailed comment. Our next question is from a gentleman who has a PSA of 3 at the age of 55 with a father that has been diagnosed with prostate cancer. What do you recommend for this patient to do?
So, the PSA number is always a bit controversial, and it seems like, everyone gets their lab test and a 0 to 4. And if anyone has a PSA that's less than 4 and they come to see the urologist, they wonder why they're there. It almost seems like 2.5 is becoming the new 4. So that's one caveat to that. The other thing to kind of think about, and they've done studies looking at that, for most men, your PSA typically is less than 1 in the 0.7 ranges and things of that nature. So in looking at that as a baseline of comparison, a PSA of 3 at 55 potentially is a little bit high. Even though the guidelines that just came out in May don't kind of make a comment that this concept of PSA velocity, meaning your PSA, the rate of change of the PSA from 1 year to the next, for example, shouldn't necessarily be used as a solitary measure to make a decision on biopsy, meaning that if everything else is fine and your PSA changes just by itself without checking again or doing something, you don't necessarily use that as the only decision-making factor, which I find a little bit intriguing. What I typically do in these scenarios is kind of see what your PSA has been. If your PSA has been 0.7 forever and now it's 3, that's a little bit of a different scenario. But what I typically do is recheck a PSA, and there are studies to show that you don't want to act on a single PSA. I always ask gentlemen if they've had any kind of ejaculation within a few days of a PSA, that can sometimes falsely elevate a PSA. So usually if we have gentlemen that just come in with one PSA, we repeat it 2 to 3 weeks, 2 to 4 weeks afterwards, and see if it downtrends, because we don't necessarily want to act on one PSA. Sometimes you can look at biomarkers and things of that nature. However, with a gentleman at 55 with a PSA of 3, I'd want to really kind of explore that from that standpoint, because especially I'd want to look at the PSA history as well from that standpoint. So especially with the family history, that's one that I would pursue. I would get an MRI scan and definitely do a rectal exam and go from there, because my index of suspicion would be a bit higher.
Agreed completely. Next question is, what is the screening procedure for a person that had a Gleason 6 diagnosis for several years and a PSA of 10.1? This person's 75 years of age and had biopsy in July.
So this gentleman looks like he's about 2 months into an active surveillance protocol, really. So, I mean, technically he's on the cusp for being between low risk and intermediate risk. So if you kind of look from a technical aspect, the Gleason 6 component of this puts him in that low risk category. And in the past, there used to be this one subgrade of low risk called a very low risk. If you had 1 or 2, possibly a 3 of a 12-core biopsy, less than a third of the biopsy, or no more than 50% of any of those individual cores being positive, that would have been a low risk category. PSAs 10 or less would be low risk. 10 and 20, above 10 and 20 would be intermediate risk. So you're kind of on the fence from that standpoint. So at 75 years and just had a biopsy, you'd really have a very, very strong discussion about whether or not active surveillance would be an appropriate aspect. We don't have any information on the rectal exam, but one could argue that's the most subjective part of a discussion, whether there was an MRI scan before that gives some information about staging. Being a true low-risk prostate cancer, sometimes there's an argument of whether he meets any kind of criteria for staging at all, from that standpoint. But you meet every criteria based on this information for the consideration of staging. And then really a discussion about someone's comfort level for active surveillance, because that does involve PSAs every 3 to 6 months, a consideration of repeat imaging, and a biopsy pathway. And then, something that comes into play, depending on age and comorbidities and things like that, is when does one go from a active surveillance protocol to a watchful waiting protocol? But I assume if at 75 you've undergone a biopsy, as someone who's got a 10-year lifespan and enough health to undergo a biopsy and have these discussions at 75 years. So in the next 6 to 12 months, doing another biopsy, I would assume is not going to be an issue to consider an active surveillance protocol. So those are all the things to kind of think about in terms of what to do. And, although controversial, most of the time we have conversations about focal therapy options for an intermediate risk prostate cancer. However, sometimes when people are very anxious about the concept of focal therapy, about active surveillance, could that be something that someone thinks about in terms of avoiding the anxiety of doing other biopsies and things of that nature, but only if you're able to come up with a therapy where the risks aren't worse than the active surveillance protocol. So if for someone the risks of undergoing the biopsy are far outweighed by the benefits, those are all things to think about in terms of appropriateness of either.
Well, thank you for that. Our next question is, and I'm trying to sort this out, is there much differentiation in treatment between general prostate cancer and transition zone cancer? You want to go ahead and take that?
Oh, go ahead. Go ahead.
And I'm not sure exactly what they mean by general prostate cancer, but I'm assuming, as far, I really haven't placed a big effort or thought, and I know that other of our practitioners, even within our group, feel differently about this, but transition zone cancers are most commonly we find all the cancers, and I think a lot of that had to do with the fact that was where we were able to diagnostically find it easiest, whereas you get more central cancers that we find with MRIs and now or whatnot. But are you making therapeutic decisions based upon the location of the cancer on imaging or finding at biopsy?
Honestly, not as much, but I wonder if that's going to become a little bit more of an issue as therapies like TULSA-PRO and potentially other therapies that may have a transurethral application become more readily available. I've been approached by a number of technologies that we're doing a clinical trial for this thing called Vapor, which is essentially almost like Resume, where you kind of give a transurethral application as a focal therapy. So if someone has an area within the transitional zone that's focal, and you do, it actually be a lot easier to treat than something that's in the peripheral zone, because you don't have to engage the needle as far in potentially. TULSA-PRO is an MRI-based delivery of high-intensity focused ultrasound, where you essentially in the MRI scan deliver with an essentially almost like a catheter type device, which kind of goes in, and you deliver the HIFU from inside out, which also is a little bit irrespective of size to a limit. And so you can almost treat BPH and the cancer at the same time. So if someone has a transitional zone lesion, it may be you take care of two birds, you kill two birds with one stone. And for people that don't know what we're talking about, imagine your prostate's like an orange. You got the outer rind, which the majority of prostate cancer lives in that rind. And then you have the fruit, where BPH, which is benign prostatic hyperplasia, which is where when people have an enlargement of the prostate that's blocking things, is that fruit growing that's blocking things, which most of the time is benign. Very rarely when we do procedures that we do resections, kind of like going with a spoon and carving out the fruit, that fruit may have cancer within it. And sometimes when now we do MRI scans, you can find something in that fruit that prompts us to do a targeted biopsy and you find cancer, although it's the exception, not the rule. So the question here is, if we find something within that fruit, do we do anything differently? But most of the time we do a biopsy and find it and come up with a game plan. But I think, I don't think any of us go and do a TERP to treat cancer at this point from that standpoint, because I don't think we trust the precision of that. I haven't heard of anyone doing holmium laser enucleations for cancer or anything of that nature from that standpoint. But I wonder if, as the technologies begin to explore transurethral procedures or MRI-based procedures or things of that nature, we'll begin to look at focal applications from that standpoint. But as of now, not really.
Well, I really think that just the things that we have looking forward to how we're going to be doing this 10 years now, 20 years from now, I think that's probably going to be more germane, much as you're saying, but where we are right now, it's not. So let's get to our last question. Please advise if there are new or current effective means to reduce urgency and frequency. I believe I'm starting down the path where this condition begins and gets worse. I'll just chip in on this one. There's the progression of treatments and medications, and we've got more available now than we've ever had. But these symptoms can come from a lot of different circumstances. It's not just prostate cancer. It's not just irritation to the bladder. It can be urinary tract infections. It can be obstruction, in men most commonly that's what's occurring. There's a number of new technologies that are available to treat obstruction. I know Dr. Kasseri and I are both doing water jet ablation therapy, which has really totally revolutionized benign prostate care in my practice. But even simple medications, but it's a matter of getting it sorted out with your urologist as far as whether this is coming from a urinary tract infection versus having stones in the bladder versus, God forbid, having a low-grade bladder cancer of some sort. And 15% of bladder cancers don't have blood in the urine or whatnot, they just have urinary frequency and urgency. So that's it. So there's a lot of different things that can be implemented. There's not a simple answer other than to say it's probably, if you're seeing it getting worse, it's something that should be evaluated. Your thoughts?
Yeah, I mean, so like you're saying, it depends what the cause is. I'm a big why person. Simon Sinek gets a lot of credit for that aspect of things, but I thought that way for a long time from a clinical aspect, and I think most of us in medicine, that's our concept of that differential diagnosis is we don't kind of float around kind of wondering what's going on and just randomly do things. The process of how we think through disease processes is to kind of figure out what's going on from that standpoint. And like you alluded to, there are many different reasons why someone could have frequency and urgency. So that why is a real big contributing factor to it. So a lot of our processes, especially when people don't kind of respond to the simple things, is to go through a diagnostic pathway. So if we kind of look at the typical gentleman and kind of working up BPH, overactive bladder, things of that nature, the diagnostic pathway is to kind of look in the bladder to understand the anatomy, measuring the size of the prostate. There are things like urodynamic studies where you can look at the functional aspect of things. That being said, if we're kind of looking at this with a very specific discussion with prostate cancer, I kind of look at kind of two pathways. If we're kind of looking at the radiation therapy pathway of people undergoing radiation therapy, a lot of times when people start radiation therapy, there's a bit of a histamine surge, kind of like an inflammatory surge where people begin to have that, and then it calms a bit, and then it gets a little bit worse. And hopefully if people didn't go into radiation therapy with BPH and a lot of difficulty, it should begin to get better. We always, if people have BPH or difficulty urinating and they're really committed to wanting to do radiation therapy, we do a very full evaluation of their urinary symptoms and things like that, so that if they have something that requires further workup or or managing that before doing radiation therapy, or even advising them not to do radiation therapy. We know that so that we're not dealing with that afterwards. And with radiation therapy, if someone has an obstructing prostate, you really can't do much short of a UroLift or something like that for about 18 to 24 months. And with proton therapy, which is a form of radiation therapy, some proton centers don't want you to really do anything for a long, long time. So that's good to know. Sometimes, this frequency and urgency through radiation therapy, you can use an isoflavone type of device, a supplement that can sometimes help. Sometimes ibuprofen, Tylenol, those type of things can take the inflammatory aspect of things out of the way. With surgery, some of these things you want to be mindful. Is there anything going on? Is there an obstructive component of things? Because usually with surgery, people complain more about the stress incontinence immediately after the procedure, coughing, sneezing, lifting, causing leakage, which for that first 6 months to a year, people are looking to get better from. And we a lot of times have people see pelvic floor rehab specialists to help with that aspect of things. So if someone's having frequency and urgency that's persistent through that experience, you want to make sure there's no urinary tract infection, there's nothing going on, or if you have to look further and make sure there's no narrowing or some other thing going on from that standpoint. But in terms of general, unrelated to anything else, then we kind of work up a variety of different things that could potentially cause frequent and urgency in a man from that standpoint. So I hope that answers, the very, very wide variety of reasons men could get frequency and urgency.
Perfect. Well done. Well, thank you to all who submitted those great questions. We had another presentation that was pre-recorded for the program, but unfortunately, due to technical issues, we're unable to view it on today's webinar. It'll instead be emailed to all attendees after the webinar. It's very important discussion regarding patient advocacy and access to quality care, pharmacy benefit managers, and additional support resources made available through the FLASCO patient portal. So we can encourage all attendees to watch it. If you'd like to be added to our mailing list for patient advocacy, please email info@flasco.org. So I'd like to thank Dr. Kassarian for presenting this evening and leaving us with this meaningful information. I'd also like to once again thank AstraZeneca for sponsoring this webinar. As a reminder, all of the handouts mentioned in this webinar can be found in the confirmation email, as well as a follow-up email that will be emailed to you following this program. Additionally, this webinar was recorded, so if you missed any part of it and want to hear it again, it'll certainly be available on the FLASCO website soon. So thank you for joining us tonight, and we hope you'll join us for more webinars in the future.